that you would cure the patient. What is this generation's version of GOG 111? What will mass AI integration into daily practice look like? What does a doctor do? What does a patient do, their family do when it says, oh, consider this or consider that? Hey, today I'll be answering questions you have sent to me across Oncology's social media platforms. I'm Dr. Maurie Markman, and this is Ask Me Anything with Oncology. Let's check out Twitter. There's a question, a very important question, asking about the optimal duration of PARP inhibitor maintenance in ovarian cancer. What data do we have to inform current strategies? I think when we talk about maintenance, we do need to talk about in ovarian cancer two different settings. The second, which was easiest to highlight, which is recurrent disease, where traditionally we've given therapies as long as they're tolerated until the patient ultimately progresses, because in the second line setting, we really don't have curative therapy. Don't get me wrong, we have therapy that substantially prolongs survival in the recurrent setting, but the idea is that the disease will ultimately occur. So as long as the patient's responding, continue to progression. Now, that may no longer be an accurate statement. We certainly have patients in the recurrent disease setting. We're getting PARP inhibitors, go year, 2 years, 3 years, 4 years, and it may very well be appropriate to stop therapy. Today, that would be a discussion with the patient, because we really don't have data in a wide spectrum of patient populations in ovarian cancer to answer that. Certainly in other diseases, we've begun to stop therapy after several years, for example, immunotherapies in some of the advanced, patients with advanced cancers. But in ovarian cancer, traditionally, we have given these therapies, again, assuming they're tolerated, until progression. In the other setting, which is one probably most people are thinking about, which is the maintenance strategy after primary chemotherapy, we do have data. We have different PARP inhibitors. We've actually looked at different endpoints. One is 2 years. Another drug is 3 years. What is best? Clearly, there are some patients that say, well, I'm doing well. I'm worried about recurrence. Can I take it longer? Am I able to take it longer? The concern there, of course, is not only the effects on fatigue, bone marrow function, but also that underlying risk, which is very real, of myelodysplastic syndrome and acute leukemia that could occur with these therapies that are PARP inhibitors. The data suggests that this is not common, maybe 1 out of 50 patients, maybe a little higher, but certainly the question remains open. What is the optimal duration? But today I would say somewhere between 2 and 3 years based on existing data. Are you a reader? Any favorite books that you'd love to recommend? Wow, I am a reader. I love mysteries. I love science fiction. And actually, quite frankly, I'm one of those strange people that actually likes to read about, questions of public policy, particularly in healthcare. And today, of course, I'll read anything that talks about AI as it relates to healthcare. There's certainly more of that coming than in the future. Let's check out LinkedIn. What a question that was asked. What will mass AI integration into daily practice look like? How can clinicians keep human touch present in cancer care while utilizing AI? I just, at a personal level, I cannot overstate the magnitude of the relevance of the question. I go back a long way, several decades now, where, of course, there was no social media. The internet didn't actually exist except in research forms. Communication was by telephone and then by fax. We are moving so fast. I don't think there isn't any question that AI will be integrated. It is being integrated now. There are so many parts of AI that will be positive to enable doctors, patients, their family, members of society to put together the information in a reasonable manner. But the speed at which this is occurring simply does not give us time to think about all of the implications. And of course, we all know there are these things now that are called hallucinations, where AI doesn't want to say, I don't know. It gives an answer. Is it true? Is it not true? Is it partially true? What does a doctor do? What does a patient do, their family do, when it says, oh, consider this or consider that? Is that based on good data? Or is it AI trying to give an answer to a question where there is no good answer? My thought is the medical community at large, and then the oncology community specifically, must get together, work together, not individually, oh, this health system versus that health system. We won't survive with that. We need to get together and figure out as a group, as a community, what is the best way to move forward? How do we test products? How do we test upgrades of products? How do we advise our systems, our individual doctors, and not only oncologists, of course, the primary care doctors, et cetera. We need to figure out a new way of evaluation that takes the best technical minds, clinical minds. I would add philosophers, ethicists in this discussion, because leaving the individual doctors on their own to figure it out won't work, and that's potentially fraught with great danger. So we need a systematic approach, again, not a health system, the entire system to work together, not to tell doctors what to do, but to advise on various approaches, putting these minds together to help what will clearly be integration into daily practice. If you could only watch 3 movies, TV shows for the rest of your life, what would you pick? Well, the answer to that one is very simple. First, The Pit. For those of you who have not watched The Pit, I can tell you it's quite accurate. And I loved, of course, and it's coming back, Ted Lasso. And if you ask me what I think the best movie of all time is, there's no question about that. It's On the Waterfront. For those of you who have not seen it, see it. There's a question here: are ADCs overshadowing the emerging activity of T-cell engagers and bispecific antibodies? Clearly, ADCs now are having a day. There's certainly a number of very effective drugs in a wide variety of tumors, particularly in the gynecologic oncology space, which is my own clinical and research interest. There are so many companies that are working on these variations of these. But, this is sort of typical. There was, immune therapy came out, many different drugs, many different companies. Drugs may seem very similar, but everybody's working on them, and then we move on. So I'm not actually concerned. We will see ADCs hopefully progress, both in terms of effectiveness and reduction in toxicities. But the nature of oncology, the nature of our clinical, laboratory, pharmaceutical research communities is they move forward in very positive ways, and I think really very quickly, probably helped by AI in the future, to come up with solutions for difficult clinical problems. All you have to do is look at the situation with KRAS and pancreas cancer to know how much progress we can make if we work together as a community, research and clinical. Well, here we're going to check out Instagram. What a question. What is one piece of personal and professional advice you receive that has stayed with you? Well, there's so many pieces of advice I've received, but I would have to say that the one that I've always thought about is taking care of patients, and particularly cancer patients, which of course has been my career, is a team effort. Yes, as the oncologist in charge, I might be that individual that answers the question of the patients. But the input into the answer and carrying out what needs to be done is a team effort. It isn't just one doctor. It is the team. And of course, that team is large. It includes other doctors, obviously includes nurses, technicians, pharmacists, behavioral experts. It includes the people that do the registration into making sure the patient is comfortable with what they're doing and changes that are necessary. It includes people helping to park the cars in the valet services. All of these individuals help that patient and her or his family. In my case, it's her, because I've taken care of females in gynecologic cancers. But I just want to emphasize, nothing is done alone in oncology, healthcare in general, but certainly oncology. It is always the team, multiple people working on behalf of the patient and their families. Next question here is, what is this generation's version of the GOG 111 trial? Of course, this questioner knew my era. GOG 111, for those who don't know, was the trial that basically added paclitaxel to cisplatin, changed the face of management of ovarian cancer. And quite frankly, that, multiple decades ago hasn't changed. Yes, we use carboplatin now, but carboplatin and cisplatin are the same drug with a change of toxicity. That revolutionized the care of women with advanced ovarian cancer decades ago. And the question is, what is this generation's version of GOG 111? My answer is, it hasn't happened yet. I'm waiting for it. I have every reason to believe we'll see it. But a drug or a combination regimen or some other approach that would change the entire paradigm in the management of ovarian cancer, we're waiting. And I hope it occurs during my lifetime so I can see it. I have a question from Facebook. How does optimal sequencing of chemo-IO differ in MMR deficient versus proficient endometrial cancer populations? I don't think that the sequence necessarily changes. Clearly, the benefits of IO are much greater, both in terms of response rates, but also in terms of duration of response in the deficient population, as we've seen in actually in other tumor types as well. I'm certain that with future trials, iterations, how we use IO and chemotherapy is going to become more differentiated based upon not only this particular molecular finding, but others. But right now, I think IOs have added a tremendous amount to chemotherapy in the endometrial population. I don't know that we would necessarily change the sequencing. We certainly might change the length of time the patient's on therapy as we move forward. But right now, I think it's really the end point of benefit from the IOs that really makes a difference here. Let's look for a moment at online forums. Here's a very interesting question. How far is AI from finding a cancer cure? And then, shouldn't the big AI companies work specifically on medical research for finding cures to disease rather than trying to perfect their chat box? As far as the second question, I couldn't agree with you more. Yeah, chat boxes are of some value, but I think somewhat questionable. But the opportunities with AI, and we see a number of companies that are actually specifically developing products for research, for looking at novel drugs, novel strategies. I would suggest that the AI could be used potentially to pull out information from the electronic medical record, HIPAA compliant, protecting privacy. But when you think about the tens or even hundreds of thousands of patients with cancers who've received thousands of different approaches, might there be information within the records that could be pulled out that said, whoa, this combination really was effective in the real world? Could AI be helpful with that? I would suggest yes, and I would hope we'd see more of that type of effort in the future. I absolutely agree AI companies should work on research in this regard. It can help the pharmaceutical companies. It can also, as I said, find information that's out there, but it's too complicated, too diffuse to get an answer to today, just by looking at the information with human eyes and human brain. One more question is, what do you wish more people knew before getting into the field of oncology, whether as a clinician, researcher, or both? I think this is a really important but quite complex question. I will go back myself to my first introduction into oncology, which would have been a number of decades ago. In the earlier days, and I would suggest that that thought process that I'm going to talk about now probably continues, one saw the advances in lymphoma treatments, Hodgkin's lymphoma, non-Hodgkin's lymphoma, acute leukemia, childhood cancers, particularly leukemics, saw these new therapies being curative. Saw bone marrow transplantation as developed at Fred Hutchinson, Johns Hopkins, and other places, being curative. They also cause death, but they can be curative. And I think many individuals over the years, over the decades, picked the field of oncology because, yes, it was very complicated. Yes, you could do so much to help patients. But that cure, the big C, meaning you'd give the therapy, cancer would go away forever, was the present or was going to be the future. What I believe we see now, clearly because of the revolution in our understanding of the biology of cancer, the complexity of cancer, the molecular events that occur, the evolution of cancer over time, drug resistance, et cetera, we've made enormous progress, and that progress continues. But cancer is appropriately seen as from a clinical perspective, as more of a chronic disease process where survival will be substantially prolonged for years. Maybe the patient will never have the cancer come back, even if it isn't, quote, cured at a molecular level, and of course, die of something else. Bottom line, it's an extended chronic disease process with recurrences, remissions. Survivorship becomes increasingly important. Toxicities of therapy become more important because they're not just acute, nausea and vomiting, bone marrow suppression, but these therapies may be taken for years. So the idea of going into oncology that you would cure the patient, or most patients, we just had to come up with the right drug, clearly occurs and will occur more in the future. But the vast majority of patients we care for, certainly in the solid tumor space, which is the vast majority of cancers, the idea that we're going to come up with that drug that's going to cure all the patients or most of the patients, as opposed to having a wonderful response, prolonging survival of excellent quality as defined by the patient, that is, I think, hopefully what individuals who come into the field will see as that opportunity for the future. Complex area, complex discussion, though. But yes, I think it's some more of thinking about cancer as it is today and it is likely to be in the future. It's a very exciting, incredible area. The impact on patients and their family cannot be overstated, but it's not that we're going to give a drug and the disease is going to go away. That's unlikely to be the future of oncology.